Hello, everyone. This is Sherry with the CGH Health Foundation. Welcome to our Growing Healthier program. These programs are sponsored by the CGH Health Foundation. In our Growing Healthier programs, we try to educate you about important health topics and introduce you to some of our providers and the services that we have here at CGH. The programs are hosted by Dr. Bill Bird. He's our Chief Medical Officer. And today he's going to be talking to Dr. Robert Pody, who is a new provider for us in ophthalmology. And Dr. Pody has been able to bring some new services to us. And I think you'll really enjoy hearing about those and getting to know Dr. Pody. Before we go there, let me fill you in or bring you up to date on some things that are happening at the Health Foundation. Our director, Joan Hermes, the longtime director of the Health Foundation, will be retiring soon. And Amanda Blaine is going to be taking Joan's place. Joan and Amanda have worked together for 18 years. And so Amanda will carry on the work of the Health Foundation and all of the great programs that we offer. And then to replace Amanda, we have hired Sierra Bushman. And so you can be assured that all of the programs that the Health Foundation is able to provide to our community will go on. And before I turn it over to Dr. Bird, let me talk about next month's program. May or June is Headache Awareness Month. And so we're asking Dr. Preeti Joseph to come on board with Dr. Bill and talk about migraines, diagnosing them, treatments that are available. And that program is going to be on Thursday, June 13th at noon here on Facebook Live. And with that, it is time for Dr. Bird to take over. Are you ready, Dr. Bird?
I am, Sherry. Thank you for the introduction. Welcome, everyone, to Facebook Live for the month of May. Good month in terms of, we'll get to interview Dr. Robert Pody, who is, he's been here a while now, but still a relatively new ophthalmologist here at CGH. So without further ado, let's get Dr. Pody on. Hi, Dr. Pody.
Hello, hey, good afternoon.
Good afternoon to you too. So before we get into like the medical questions part about people's eyes, since you're new to CGH, I thought I would give you an opportunity to tell us a little bit about yourself.
Sure. I'm a Midwest guy, born and raised in the Midwest. I've been in practice in Illinois in LaSalle County for the last 28 years, just to the south of us here. And operated in LaSalle, Peru, Spring Valley, Ottawa, Mendota, Streator over the years. I grew up in Michigan, spent the first 22 years of my life in Michigan, going to school at the University of Michigan, and then medical school in Chicago, residency back in Detroit, and lived in small town North Central Illinois since that time. And I'm happy to kind of continue my career in Dixon, Sterling area. Like Bill said, hasn't been a long time I've been here, but I didn't just start yesterday. It's been, three months or so, 4 months, and enjoying my time, getting to meet all the, new coworkers and people of the community here.
Great. Well, yeah, welcome. So let's talk about keeping our eyes healthy first before we go into some of the unhealthy things that happen to the eyes. So what would your suggestions be, Bob, for folks to try to do all they can to keep their eyes healthy?
So I think, the eyes are a lot like the rest of the body. I mean, certain eye diseases, if you have hypertension, high blood pressure, diabetes, high cholesterol, overweight, all those things affect the vessels. And there's vessel diseases in the retina, those can be risk factors. So things that you do to keep your body in general healthy will help your eyes as well. This time of the year, with fireworks coming up on the 4th of July, and people, working with things in the shop, it's important to wear safety glasses at all times for those types of activities. Those are things that, we're only dealt two eyes, and we want to protect both of them. And safety glasses is a big thing to help prevent injuries.
In my old age, I've started to wear like safety glasses when I mow the grass. Um, I don't know. I mean, to me, it feels like maybe it's a little bit helpful as you're running over. I should probably be picking them all up, running over like twigs and sticks and
Yeah.
stuff and everything that gets flying around. Those are the kind of things where you're just like, oh, I want to make sure I don't have something like that inadvertently cause.
Yeah. Yeah. Or if you're outside with a pair of sunglasses or something like that on, give you some protection. But I mean, I wear glasses, so when I mow my lawn, I've got glasses on. But
Yeah.
I occasionally see patients, and it's not so much the person cutting the lawn. A lot of times it's a kid that's off to the side and something shoots out of the mower and hits
Yeah.
them, because just the angle. I think probably on top of the mower that you're not going to get hit, but off to the side,
Yeah.
So be
Yeah.
cognizant of that when you're cutting the lawn, that people aren't around you, that you could shoot out a twig and hit them in the eye.
Yeah. One of my childhood friends had one eye because got hit by a rock from a lawnmower.
Or yeah.
Yeah. So, okay. I want to get into some of the things that I think that I know that you do that are a really nice service that we haven't had in the community for a while. And one of those things, Bob, are retinal injections. So I guess I would ask a little bit about retinal injections, or what are the patients that are good fits for retinal injections?
Okay.
How effective are they? And how do you go about, what does it entail getting a retinal injection? So
Okay.
I'll leave the floor to you on retinal injections.
So in my almost 30-year career of ophthalmology, there are certain things that I would say are some of the most useful developments. I think retinal injections for treatment of retinal disease, which started in the early 2000s, is probably one of those top things, because before that time, a lot of these retinal diseases, unfortunately, there was no good treatment. Nothing really helped. A number of retinal diseases now are treated with injections into the eye. Those include like diabetic retinopathy, macular degeneration, retinal vein occlusions. Those would be the big three. And I always tell patients, I know it's almost like a nursery rhyme, stick a needle in your eye. Years ago, I never thought I'd be sticking needles in patients' eyes over and over again every day. But patients usually do very well with these injections. It's not 100% pain-free. Sometimes patients don't feel anything. Sometimes they feel a little poke. It's quick. You don't see the needle coming because you've got a bright light in your eye and you're looking usually up and to the left. And it's quick. Afterwards, there's not generally any pain associated with these injections. There's usually maybe a little foreign body sensation, not so much from the injection, but from the betadine that we clean off the area around the eye with. That can be a little irritating. So we usually have patients use some teardrops that day, artificial tears, and we rinse the eye out well before they leave here to make them feel better. But these injections, they're not a one-shot cure. That's one thing we tell patients at the beginning. It's a series of shots. We generally start them each month. And then if they respond well, we can increase the interval in between these shots. And we can hopefully get out to 3-4 months of getting these injections. The injections work well for all of the diseases, eye diseases I talked about: diabetic retinopathy, macular degeneration, vein occlusions. I mean, back in the 90s when we used to do laser for these, patients didn't usually have an improvement in vision. We tried to keep them the same or slow the worsening. And the same thing with macular degeneration. Those patients did horribly with laser. But it was the only thing we had back then. But when these shots came out and were developed in the early 2000s, like 2003, 2004, many patients have avoided losing vision and going blind from these diseases. In terms of procedures, any procedure you do in the body, there's always rare risks. I mean, the major risk of these would be things like bleeding in the eye or infection, but the risk of that would be less than 1 in thousands. It's very rare to get that type of an issue. And there's things that can be done if you get an infection in the eye afterwards too. But like I said, I think it's patients, not so much that they enjoy getting their shots, but they enjoy seeing the improvement in their vision. And I have some patients that I've been giving shots for, literally had 100 shots. And they patients that you get to know because you're seeing them every month or two for over 10 years. And the staff gets to know them, and it's, it helps patients keep their vision, which, they can see their grandkids and things.
Yeah, very, very helpful to hear about that. So yeah, anyhow, for folks who are listening or would share this with other folks, just want to highlight that Dr. Pody is able to provide that service for patients. The other thing that you do is oculoplastic surgery. So obviously that's a fancy word that I work to have to say properly, but I'm going to give you the opportunity to say what exactly is that, and who needs that surgery or potentially would benefit from the surgery, and what kind of outcomes do patients have if they have oculoplastic surgery, Dr. Pody?
So oculoplastic surgery would be any surgery that's done not on the eyeball itself, but done on the lids around the eyes, the upper lid, the lower lid. There's different things that can happen to your eyelids, generally as a result of the aging process. One of the more common things is your eyelids start to droop. They kind of hang down like half-mast. And that surgery can be cosmetic, and it can also be functional. In general, the patients that I do are functional. They're patients that the lids are hanging down. They're interfering with their ability to read. When they read, they can't see well. When they're driving, it's blocking off part of their vision. It's basically an outpatient procedure that I do at CGH. The eyelids are numbed, but during the procedure of numbing, they're put to sleep by the anesthesia department for a few minutes, so they don't feel that at all. Then they wake up, and the procedure takes maybe about a half an hour per eye. And most patients get both eyes, but some patients have unilateral ptosis where they just have one eyelid that droops. Afterwards, the first day when they come in, they look like they've been in a fight. I always tell them the joke, but look what the other guy looked like or whatever. But usually by a week, they're looking pretty good. The surgery is usually very successful. It helps their symptoms. These are patients generally that are symptomatic. They're not the, 24-year-old that looks perfect and, has a little wrinkle that they're getting. These are patients that have real complaints. Other oculoplastic surgeries that I do, entropion, which is fairly common as well. I've done, I think, 2 or 3 of those in the few months that I've been here, where the eyelid rolls in and those eyelashes then rub on the front of the eye. And it's generally the lower lid that does that. And once again, the most common cause of that would be an aging process. There's a procedure, an outpatient procedure, where I tighten up the lower lid and roll the lid back out. Like the eyelid surgery, patients are put to sleep for a few minutes while I numb that area up. The procedure itself takes maybe 25 to 30 minutes. They come in the next day. Once again, they're kind of bruised, but it usually resolves their symptoms. And surgery is very successful, usually lasts a number of years, 10 or 15 years. And these are usually patients in their 70s, 80s, late 60s that are getting this.
Yeah. The patients I've seen that have had that have been really miserable.
Oh, yeah.
Oftentimes, if you have your eyelashes sticking into your eye, essentially, that is not a fun experience.
Yeah.
Yeah. So, okay, good. Anything else on oculoplastics that we need to know?
No, I think, let me see. Just logged out on the computer here. Let me get you back.
Oh, yeah. You're back. All right. All right. Let's get to the bread and butter surgery that you do, which is cataract surgery. Bob does cataract surgery. Let's talk about what are the symptoms that a patient would have who would be potentially need a cataract surgery, who's at higher risk of getting cataracts,
Okay.
and what can patients expect if they do have cataract surgery in terms of how their vision responds to that surgery.
So yeah, like you said, that's the bread and butter surgery. That's the most common procedure that I do. Intravitreal injections, depending on the year, has been right about the same number. So they're pretty similar, but usually cataracts are a little more. Once again, it's an outpatient procedure. This one, there's not an injection. It's done just with topical eye drops. The anesthesia department does give the patient some sedation. It affects every patient differently. Some patients don't really have a memory of the surgery at all. Other patients do have a memory of it, but it's usually not a bad memory. During the procedure, patients see like kaleidoscopes of light, different colors and that. And usually before you know it, it's over. What a cataract is, per se, that's the lens in your eye that as a result of aging has become cloudy. A lot of patients have the misconception that the lens is a cataract is something we peel off the eye, but the lens sits behind the iris. So it's sitting behind the colored part of the eye. And that whole lens becomes cloudy. Sometimes it's different parts of the lens, the front part, the back part. But during surgery, basically what I tell patients is the cataract, we think of it as an onion, and we suck out the meat of the onion and we keep the onion skin there. That onion skin is where we put that implant in, and that's what gives patients better vision. In terms of implants, there are different types of implants that I use. There are regular conventional implants that give patients one particular point of focus. There are some specialty lenses that try to give patients better depth of focus that are available as well. Insurance doesn't cover those. Some veterans, the VA covers certain ones of those, which is great, a benefit for the people that served our country. They deserve it. But patients usually do very well with it. I always tell patients it's in my hands and most doctors' hands, it's a 99% or higher success rate. Most everyone has an excellent result from cataract surgery. And it's not a surgery where there's a lot of downtime afterwards. I tell patients the only restrictions I generally give them the day of surgery, no driving. Usually the next day they can go back to driving. I tell them no lifting greater than like 20, 25 pounds for a week, no swimming, no hot tub. Usually after a week they can go to full activities.
When you say these specialty lenses, and what did you say, something about long distance or something like that? What do you mean by that, Bob?
So as most people know, when they get older, they start to wear bifocals because one prescription doesn't give them good distance vision and near vision. When you're 18 or 20, you can, 30, you can see everything both far and near. The implants, when they first came out in the 80s and into the 90s, only focused for one distance. Now there are some multifocal implants and extended depth of focus implants that try to give patients a greater depth of vision. In other words, without glasses, being able to see far away as well as up close. Now, I always tell patients there are some limitations in those. They're not, you're not getting vision like when you were 18, but if the lighting is good, most patients should be able to read newsprint without glasses, drive without glasses, do a lot of tasks without glasses. In a dimly lit restaurant, you may need some reading glasses, sometimes smaller things on your phone or on the back of pill bottles you may need a little help with. But if you're looking for something to try to give you the best amount of glasses independence, those implants are the one you would want to look for. For patients that have astigmatism, they're also available to correct astigmatism. A lot of astigmatism patients may have worn toric contact lenses in the past. There are toric implants that we put in the eye as well to eliminate that astigmatism that patients have.
I want to move on to a couple other common conditions in ophthalmology. The first one is glaucoma. So as far as glaucoma goes, who are the patients that, to keep their eyes healthy, need to be screened for glaucoma?
So patients that are older than 40, I think it's probably a good idea to have a complete eye exam if they've never had an eye exam before that. Glaucoma is an eye disease. We call it the sneak thief of vision. So in general, patients do not have any symptoms with this disease, but it's something we can recognize by looking at their eye, looking at the optic nerve, checking the pressure. Glaucoma is a disease that the older you get, the more common it becomes. Certain races, African Americans, have a much higher incidence of glaucoma than Caucasians. If you have a strong family history of glaucoma, that's an additional risk factor. You should be screened. It's a disease that some patients we look at, we say they definitely have glaucoma. Some patients definitely don't have glaucoma. But then there's a group in there in the middle where we call them glaucoma suspect. These are the patients that maybe have some risk factors for glaucoma, and they may or may not be on treatment. And we're following them every year or 6 months looking for changes. I always tell patients with glaucoma that are in the glaucoma suspect category, it's not something where, like that, you're going to lose your vision. It's a really slow process over years and decades. So we watch for these changes. And if we do see some changes, then we treat them with drops. Glaucoma is generally treated with eye drops first line. Lasers, SLT laser is successful as well. Some patients opt for that first line as well. If laser and eye drops don't work, there are other surgeries that can be done for the treatment of glaucoma as well. But it's a disease that patients don't really come in with symptoms. It's something where you really have to be screened in order to know if you have it, because patients don't have symptoms of glaucoma until their vision is really poor, and then it's too late, because any damage that's there from glaucoma cannot be reversed. We want to halt it in its tracks where it is.
Yeah. Does the screening have any similarities to, like, let's say colon cancer screening or something, where, like, if you have risk factors, you're supposed to get X number of years screening, and if you don't have any risk factors, it should be a longer period of time, or just a one-time screen? Any thoughts on that?
It would be what I would find on exam when they come in. If they come in for their initial exam and everything looks great in their eye, depending on their age. If they're in their 40s, I may say come back in 4 years if everything looks perfect and I see absolutely no issues. If they had some risk factors for glaucoma, if they had some changes on exam that were suspicious, I may be seeing them every year. If they're 65 or above, probably every year they're going to be examined. Really young patients, 20s, 30s, glaucoma is exceedingly rare. Same thing in juveniles in their teens. Those patients, in general, ophthalmologists aren't usually seeing them frequently, if at all, unless they have an eye injury or something like that.
Okay. I guess I would have the last question I would have is for macular degeneration, in terms of the screening process for that, or what your recommendations are, just to kind of get in the loop with someone like yourself to identify that as early as possible.
So macular degeneration, I would say the same thing. I mean, the patient comes in at 40 or so and has a complete comprehensive exam, and we dilate them and their macula looks perfect. They're not going to develop macular degeneration overnight. Maybe every 3-4 years at that age, if everything else looks good. In general, patients with macular degeneration, when we start to see them, they get small little age spots, we call them, in the back of the retina, what are called drusen. If we see those types of changes in patients, generally then we recommend they begin ocular vitamins like eye caps or PreserVision, store brands as well. Studies have shown that decreases their incidence of vision loss with macular degeneration. We also give them what's called an Amsler grid. It's this checkerboard type pattern that they take home and they look at it with each eye individually, because as macular degeneration progresses, patients a lot of times can get some distortion in straight lines or blind spots in their vision. Some patients, unfortunately, don't notice those changes unless one eye is covered. Sometimes they don't notice it until they come into the office and we cover up one of their eyes and they say, oh, I can't even read the eye chart out of this eye anymore. So it's just a way at home where we force them to look at each eye individually at this grid. That way they can pick up changes early. And patients that are diagnosed with dry macular degeneration on vitamins, they also have that grid, because if they develop wet macular degeneration, that's where the injections come in. So dry macular degeneration can progress to wet. And in general, that's where patients are starting treating with injections. There are a few injections out there now for dry macular degeneration, geographic atrophy. The results of those are not quite as good as the injections for wet macular degeneration, but we're in the infancy of that. Those have only been FDA approved for the last couple of years. And when the first ones came out for wet macular degeneration back like 2004, 2005, they weren't as good as the medicines we have now. So as the years go on, I think those treatments become more and more successful as new products are developed.
Yeah, well, that's a good thing. Here's a question from Diana. I heard those need cataract surgery should get new glasses first, and if you are still having problems, have the surgery. This was information from a doctor in the Quad Cities. I need surgery in my left eye, but I don't feel ready.
So yeah, I always tell patients they have to be ready for the surgery. You never want to, tell someone they have to have cataract surgery. They have to have visual complaints that they're ready to have the surgery. They have to be comfortable with the surgery. Now, every patient that I see with a cataract, I don't try them in new glasses, because if it looks like their vision is not going to improve much in new glasses, it's just a waste of money to get the new glasses. But if it's borderline and they want to try the new glasses and see how they work, I'm always open to that and have patients try that. And then if they try the glasses and it doesn't work, the next step is having the surgery.
Yeah. So it sounds like it's not the glasses thing is a possibility, but it's not like every time you need new glasses first type of thing.
No, because if, when they're in the room, we refract them and we can see what their vision potential is with a new pair of glasses. And if it's not significantly better than what they have now, it wouldn't be worthwhile.
Right. Yeah, it's like if it's all cloudy, what's the point in glasses if you're still looking through the cloud?
Right. Yeah.
If you will, right?
Yeah.
So, okay, great. Thanks for the question, by the way, Diana. All right. That's all I have to chat about today, Dr. Pody. I appreciate your time.
Thank you.
Very good conversation. And just for the folks who are watching this, who haven't met Dr. Pody or known about Dr. Pody, he is quickly obtaining a very good reputation here at CGH. He's a very nice fellow and does really good work as far as taking good care of patients, both in the office and in the OR. So I'm really glad to have you, Bob.
Well, thank you. It's a pleasure being here, and it's a pleasure talking to you this afternoon.
Yeah. All right. Well, I'll let you get back to your day. Have a good one. I know I'll be seeing you soon.
Okay. Sounds good. Thank you.
All right. Take care. All right. Bye.
Bye.
Okay. I have some announcements I wanted to make. So congratulations to Stormy Andrew, our Employee of the Month. Stormy works out at Lynn Boulevard. So congratulations to her. Cassie Jackson recently won the Daisy Award. She works on our OB floor. Our OB floor does excellent work with patients, and so congratulations to Cassie. We have a lot of Daisy Award winners on the OB floor. Bailey Smith in the ED. Congratulations to Bailey for winning the Sunshine Award. She's a CNA down in our ED. And then we wanted to highlight Sauk Valley's 39th Annual Child Fair. That's Saturday, June 1st from 9 a.m. to 12 p.m. My understanding is that we are a major sponsor of that, and we will CGH will have a booth there at this child fair. Blood. Always need blood. So June 6th, 9 a.m. to 6 p.m. up north of the hospital, North Locust, which is where our pediatric rehab department and our foundation is. We're going to have a blood drive. So please, if you are available that day, give blood. Thanks. This is an in-person talk Dr. Song is doing for people who have bladder issues. So that'll be, I think, where's this at? I'm trying to find this in the thing. I think that's here in the hospital. Is that right, ladies? Okay, so it's in our auditorium on the jutting out south side of the hospital. So that's going to be June 11th, if you're interested in coming to that. And then, as Sherry alluded to and mentioned at the beginning of this broadcast, Dr. Joseph will be. I've had Dr. Joseph on at least a couple times. She's always does a really good job, very informative. So she'll be on June 13th to talk about migraines and treatment options for migraine headaches. So looking forward to that. Okay, well, thank you for taking the time to watch this. Share this with those who you think might be interested. Until next time, have a great day.